I could start. As you know, we don't have any multidisciplinary clinic to deal with amyloidosis patients in New Zealand. I just wondered what the prospects might be of Australian clinics accepting New Zealand patients.
Did you hear that, Simon?
I did. It's a great question. It all depends on when Jacinda opens the borders to us dirty Melburnians. I would love to be over there. Look, I think one of the things that I think the Australian Amyloidosis Network's tried to do is work closely with New Zealand specialists. I think initially what we really tried to do is to highlight to pharmaceutical companies that there is this wonderful country called New Zealand, and that New Zealand is excellent to experiment on. I mean, no. In all seriousness, I think that the first thing we want to do is to get clinical trials into the country, and I think that I think Hugh Goodman and Tim Sutton and Ed Gain have been fantastic, along with the patient network people, and because I think that helps to raise the awareness and just to let everyone know that we are here and we're happy to be consulted. But I think in terms of actually going over there, that's logistically going to be a bit tricky. But we're very, very happy to help in any way. I don't know whether Peter has anything to add to that.
So it's a big deal to leave your country to get a medical opinion. Particularly, I guess, in these days where you can do teleconsultations and all sorts of stuff, but you need expertise in New Zealand. You can't make someone interested in amyloidosis. You have to have clinicians that are willing to set that up and take that on. So in fact, for example, in Australia, the first clinic was in Sydney and then in Brisbane, and we had to wait, I think, 5 years before someone came to Melbourne, which was Simon. So Melbourne was a very difficult area for us until Simon came, because everyone was an amyloid expert. It's probably different to New Zealand. In Australia, every haematologist is an expert in amyloidosis. And so it was very difficult to get good advice into Melbourne. And similarly, we had problems with Perth because we had no one there, but then a doctor who had spent 2 years in the amyloid centre at the Mayo Clinic returned to Perth, and he was obviously keen as beans. And so all of our centres have been set up around doctors who've come back, and one of them is a champion of the disease and willing to take that forward. Because you've got to educate yourself. It's not knowledge that you acquire often just in your general training. You have to have had some exposure at some point. So that's one thing. The other thing is that there are different models of clinics. So like our clinic is, a physical clinic where people come in, there's a cardiologist, renal physician in the room next door, whatever. But, there are a number of specialty clinics in rare diseases around the world which are virtual. Maybe this is something that will work for New Zealand. And that needs, again, it just needs people to be interested enough to set aside a particular time and hopefully have some organisational capacity to make the clinic work. None of our clinics have got any funding from government or institutions. It's sort of been in kind, sort of support. But that's all you need to get going. So there are different models. I don't know what would be the best. I mean, a number of patients I know from New Zealand, I've seen a few, Simon's seen a bucket load, but that is not the future for amyloid care in New Zealand. That's like a stopgap measure. Yeah.
The Haematologist Professional Organisation is, as I understand it, Australasian, covers both New Zealand and Australia. Is there a lot of cross-fertilisation, if you like, with knowledge through that association, or is amyloidosis too minor to really register?
I'll answer that one, Simon. So look, we had a number of strategic directions we took in Australia a number of years ago, and one of them was to introduce amyloidosis into every specialty conference that we could. And haematology was the first. So since 2007, so that's a long time now, there's been an amyloidosis talk at every haematology meeting. So that was easy because we're haematologists, we can infiltrate it. And we've done that. That's been in the Cardiology Society of Australia and New Zealand's annual meeting as a distinct session for the last 4 years, I think now. There is a lot of professional sort of interaction. I chair the Australian Australasian Leukemia and Lymphoma Group, which is our trials network, which incorporates amyloidosis. And we've spent the last couple of years fairly vigorously lobbying the New Zealand government on behalf of our New Zealand members to improve things around drug access. I don't know that we've had a lot of success, but I know what will happen if we do nothing, which is nothing will happen. And in fact, just before Christmas, we wrote, our group wrote a letter, and in fact 15 other trial groups in New Zealand joined that letter to the health department to try and see if some of these issues could be addressed. It's all being confused at the moment by the, I guess, dismissal of the district health system in New Zealand. So I certainly don't know, but none of my New Zealand colleagues seem to know exactly how that's going to pan out. But maybe that'll be an opportunity to get some of these issues sorted if you've got, one payer. So yes, there is a lot of interaction. I would say if someone doesn't try to stick up for New Zealand, they will, I would say, generally get lost in the scheme of things. So you need to have your New Zealand members banging on the door all the time to make sure these things are kept at the forefront of everyone's attention. Sorry, long answer. Any other questions?
Got a more technical one. Is there any evidence that in TTR wild type that the monomer misfolds before it forms part of a tetramer?
Oh, Simon.
Was the question, was there any evidence that there's a monomer and then it forms a tetramer?
Yeah, well, the monomeric form actually undergoes the misfolding rather than somehow where it's in a more stable tetramer that it somehow falls apart. It seems to me that we might have things backwards, but the evidence is the evidence.
I didn't quite catch it, but I gather that the question is it that the monomers are just produced and they don't form the tetramers? That
they misfold and therefore they do not form tetramers. They misfold as monomers.
That's possible. I'm not aware. I haven't actually seen any data about that, but it makes a lot of sense. I think proteins, my understanding is that the transthyretin likes being in a four-leaf clover tetramer type pattern, and I would suspect that there's a lot of there is some leaching out of monomers chronically. I think what you need enough of them to start to kink together and aggregate together to form a template, and once you've actually laid down some amyloid, it will continue to build. And I think it takes quite some time for that to happen. So I don't know if I've really answered your question. I guess the short answer is I don't know.
That's fair enough. Is there any data on...
I'll answer that one, sorry, before you say. My understanding, I'm not a structural chemist, My understanding is that the hepatocyte, the liver functioning cell, makes the monomers and they assemble prior to secretion in the hepatocyte. And so you're actually not having, it's not making monomers which then join together in the blood. So the secreted product is a tetramer and then it falls apart. So I don't know whether you make, like the light chains, some monomers escape out. I don't know about those tissues, but I don't think there's an opportunity for misfolding in the blood because it's secreted as the tetramer.
Or misfolding within the cell and then being secreted as monomeric forms.
Yeah, I don't know about that.
Any evidence for post-transcriptional, post-translational modification?
I don't know the answer to that one. That's for
Middle age have higher levels of transthyretin than women, which may account for why wild type is mainly seen in men. I suspect that women will all develop transthyretin amyloidosis as well if they live long enough. I've certainly got a couple of female patients in their late 80s and 90s with wild type. But in terms of, it's actually, transthyretin is actually a negative phase reactant. So you have, acute phase reactants like, ferritin. We see that will go up if you have inflammation. If you have inflammation, then transthyretin levels actually go down. Apparently, again, I don't have much data on that. So. Which surprises me because I would have thought if you were inflamed, that might account for why we get transthyretin depositing in places like the carpal tunnel, which is used a lot, and in the heart. We also know that patients who have been elite athletes in their youths are probably more likely to develop amyloid a little bit earlier, transthyretin amyloidosis. So I've got a lot of ex-footballers and people who have had manual jobs, farmers, bricklayers, those sorts of people. But I'm not aware that transthyretin levels will increase or change depending on other disease states.
Can I just ask about transthyretin stability? I mean, wild type is a disease of older men. Is it likely that the stability of the TTR molecule has changed as people get older? Or is it likely that it's always been unstable but doesn't actually present clinically until several decades have passed, for instance? Is it likely to be something that we're born with, or is it likely to be something that becomes more unstable with age?
I don't think we know the answer to that. I mean, I think that we know transthyretin is an inherently amyloidogenic protein. It's a protein that can dissociate into amyloidogenic monomers, and that I don't know whether it's just a build-up over time or whether that actually increases with age. I suspect the latter, but I don't know any data. But it's a good question. So you've given me food for thought. I need to go away and have a look. It's amazing what strikes me about transthyretin amyloidosis. Like if you go back, when I was in London at the National Amyloidosis Centre back 12, 15 years ago, we would see, for the whole of the UK, we would see a handful of patients in the clinic a week. In Melbourne now, we've usually got about 10 patients in the clinic and we get a new referral every week. So I think we've learned a huge amount about transthyretin amyloidosis, but there's still these sort of really basic unanswered questions that we don't know, or certainly not well known. I don't know whether you know, Peter.
No, there's obviously other factors. I mean, Simon's mentioned the mark sex predisposition. And so that's referring to difference in enough amyloid deposition to cause organ impairment. Because if you look at the autopsy series of 100-year-olds, 90-year-olds, males and females have the same amount of, they've both got the same amount of amyloid deposition. Not same amount, but they've both got amyloid depositions affecting equal numbers. But other factors have got to be involved because we've all got transthyretin. We're all making it at roughly similar levels. I know Simon said males in their middle age have higher levels, but I think it's more than that. Mentioned the elite athlete thing, but I've heard this theory a number of times, and I've often thought of it myself, is that, the amyloid seems to deposit in areas of high movement. Your heart, constantly movement, your wrists, your lower back, your biceps tendon, all these places that, are subject to repetitive movement. So whether that's, inflammation, but maybe stress, so that maybe some sort of physical stress on the protein leads it. But is it something, so what's the issue with women? Is it something to do with estrogen affecting transcription of other genes that produce something that makes transthyretin more likely to misfold? Is it the expression of something in the tissues that's the target for transthyretin? It likes to bind to, there's a variety of things, receptors, advanced glycation end products that might be something like that that's the target. So, I don't know, and I haven't read anything that's sorted out that issue, but there's no doubt that a 5-year-old's transthyretin is amyloidogenic. It's the same molecule. Any other questions? We've had more biochemistry in this talk than I've had for
Yes, right.
Does having TTR amyloidosis completely rule out chemotherapy in the event of cancer?
Short answer, no. Simon?
I didn't hear the question.
Does having transthyretin amyloidosis rule out chemotherapy if you develop another cancer?
No.
That would be...
like everything, you have to be, if you develop another cancer, you have to have an assessment as to whether someone is fit for chemotherapy. Now, if you've got very mild transthyretin amyloidosis, you got a little bit of shortness of breath, but actually your exercise tolerance is pretty good, you can still do most things, then, mild to moderate chemotherapy would be very much appropriate. If you are struggling to walk 10 metres and you've got uncontrolled fluid retention, then it's going to be very difficult to deliver any meaningful chemotherapy for another cancer. So the answer, my initial reaction is no, but everything comes with a qualification.
Was that your question? Yes. Yeah. So I think there's nothing specific about transthyretin compared to any other cause of heart trouble. It would just have to be assessed on the merits of whether the chemotherapy could be delivered given that cardiac function. Some chemotherapy agents, for example, are cardiotoxic, and you'd be nervous about giving a cardiotoxic drug to someone who's got a poor functioning heart, but a mild one might be okay. So, any other questions? Yeah. Okay.
What role, if any, do we as caregivers and patients have in keeping the trials open or even coming to New Zealand? My father has wild-type amyloidosis. Vutrisiran. There was ethical approval completed here by a cardiologist and his team, ready to be up and running by the end of May, and had the news from him that he was very disappointed that New Zealand was not part of the trial. 22 other countries are. So I'm just asking, as a caregiver or a patient, do we have any role in making any difference?
Shall I have a crack at that one, Simon? Talking about the role of...
I heard something about caregiving and patisiran.
The role of patients and carers in trying to make sure trials come to be available. So I guess, there's multiple levels to that question. Yes is the answer. Can you always get the results you want? No. I mean, we had in Australia, we had lined up the Inotersen trials. We in fact had ethics as well, and the company just pulled the trial in Australia. Not worldwide, just in Australia. And we had a similar one with patisiran recently for the hereditary amyloid patients where, you know, we'd consented all these patients, they signed the consent form to start, and they just decided to stop the trial early because it was looking so good. And so that is absolutely unethical. But, you know, these are commercial companies. They make decisions based on commercial factors, not because they're benevolent organisations. And we see this all the time with trials. And so this is a group, for us, a relatively well organised, internationally connected group of doctors in the amyloid space, still couldn't overcome this company resources. We force some compromise for them, but you know, you can't always get the outcome you want. But what can patients do? I mean, you know, look at this meeting for one. That's one thing that is building awareness, that's starting to get the messages to doctors who might be interested. They know the patients are there. Some patients take things or carers take things a step further. So Jamie, for example, we've got our equivalents in Australia who meet directly with the companies and chase them. Or if you're absolutely full of energy, you could be someone like Isabel Losada, who's, you know, off the back of her own energy, set up an international group, met with the FDA to get endpoints appropriate for trials, brought doctors together. So, you know, that's anywhere from just supporting your partner who has amyloidosis to trying to change the world and succeeding to some extent. So, yes, wherever you want to go and what your skill set is, I don't think there's really it can't be done.
I think
You go.
I didn't initially hear the question, but I think it was what role was do caregivers have for attracting clinical trials? Was that it?
Yep.
Yeah, it's a good question and a tricky one. I mean, I think Peter was right. There's lots of things to unpack, because I think part of it is, you know, the carer's role and how you can help, and access to clinical trials and, you know, novel agents in Australia and New Zealand. So one of the reasons why we set up the AN was so we could get together and have a more coordinated approach at sort of lobbying pharma, lobbying government. I definitely think that making government aware of amyloidosis and the rarity, you know, that sort of stuff never is lost. You know, I think raising awareness is always really important. I think keeping in conversation with the AAN and encouraging your specialists, if you've heard of a trial and they haven't, encouraging them to think about opening it. But you know, the closure of trials is very difficult, and my sort of feeling is that if there is a trial that's open in New Zealand, then the doctors, I mean, we have to go through the protocols and make sure that we feel that it's ethical, because we're not going to put it through an ethics committee until we're happy to recruit patients to it, number one. And then the ethics committees go over things with a very fine tooth comb. So if your doctor is saying, we think this would be a great drug or this would be a great trial, you know, I'd encourage you to consider going on it as soon as possible, because, you know, we've had this issue, I think, almost with every trial we've had recently. Though amyloidosis is becoming increasingly known about, or that all the trials are closing early, which is very frustrating because we'd like to get as many patients on there as possible. But I think, we have a clinical trials page on the amyloidosis website, which we update regularly. And we will continue to do so. So for New Zealand, I'm always, telling pharma they should seriously consider running their trials in New Zealand because I know that access is an issue like with Australia.
Our website is essentially run by a carer. So I put the effort in, it wouldn't have happened without her. Sorry, yeah?
Would it be useful for New Zealand and Australia to start a conversation about joining forces? We don't have a clinical rule here, and you have, 4 or 5 now, so you've got professionals that have a passion for it, and we've got ours over here, but they're very few. And you also know how to set up the systems now, and I just wonder whether it would be beneficial to do that. More power, we're better to get.
Gives us. We probably don't need that right now, but we're thinking in 10 years we probably will need that.
Professor again this evening, and he will present as well. Just having all these people involved, I think is huge. And so bit by bit, we will get somewhere. Okay, so don't be discouraged. That's what I'm trying to say. Clinical trials. Something that I've learned is that pharmaceutical companies they need to hear our voice. We didn't start this, I think, if we didn't, my husband and I, when he was quite ill at that point in time, but we had to make that trip over to Berlin because that was where the amyloidosis conference worldwide was happening. And it was there that...
Now, and it's...
Going to Berlin was an eye-opener, seeing how different governments were doing it, different pharmaceutical companies were doing it, and which is more patient-focused than the clinician side of it. And there's an ethical reason why they do that. And we were able to sort of meet a lot of the global people representing the drug company that discussed that. And they were willingly walk us through what we needed to do to get trials in and give us advice, give us resources, and so forth. And I think that is important, getting stepped in to do something rather than doing nothing, and then getting local support. MPs, clinicians, helps a lot of that as well. And if you said that nothing expected to happen to you, you won't, because it's nothing happened. So if you can set a precedent at getting gene silence in the country, others will be keen as well. I mean, when Simon heard I was getting a treatment, they said, "Can he get out?" I connected him to the person that helped us, and she said, "Yeah, we'll help with that." I think that's the collaboration between the patient and the clinician. You just can't expect the clinicians to just be doing all the work. We as patient and carers, we got to step in as well. And I think Jamie's hinted this many times, is you got to be responsible for your care, your well-being, and be aware of what's going on. And we aim to do that. And we as a group, while the clinicians are tying together, we as an association are tying in the UK group, with the US, Australia, Korea, and Europe as well. And that makes us bigger known. So when they get something, they let us know. When we get something, we let them know. And so we constantly update. And we would love for people to get involved and chip in. Because ultimately, you drive your care, especially in New Zealand.
Just wanted to hear your advice in terms of, let's say, us in New Zealand, and if we wanted to think about our next steps with limited resources that we have, and the various drugs that are out there globally. Would you advise paying particular effort or focus towards any specific drug that we should try and sort of lobby for New Zealand and Australia, or would you advise, just going out for all of them, whichever ones are out there? Is there anyone particular that you think that, you know, where your chances are, our chances would be higher?
Right, for AL amyloidosis, you should focus on getting daratumumab. And that might actually be possible in New Zealand. The reason for that is it's an expensive drug, but it's time limited. A lot of treatments go on for ages and they become unaffordable to governments. But amyloidosis is time limited. You've already got Velcade approved, so maybe that would be. In the TTR space, at the moment, if I had a choice in Australia, I'd be trying to get one of the knockdown therapies as, expensive, but might actually change the course of the disease. Tafamidis just slows it down. So,
yeah, I totally agree.
But I was saying this when we had dinner last night. We have been in touch with these companies numerous times for the last 5 years, and a lot of promises about coming to Australia with these drugs, but still not there. And why is that the case? Because they work out, they're very keen to get out of you, how many patients do you have in your country? And they find out, and it's not many. And so, even though we're a rich country in terms of world countries, we don't have a lot of patients, so we just have been knocked down and down and down. Both companies are countries of, so they haven't even started the process in Australia yet. So that's discouraging. But I think they're the drugs that have got the most bang for the buck.
Just
So Simon, do you?
as a point of...
No, I think you've answered it very well. I would agree. I think that daratumumab is an extraordinary drug. And the other good thing about daratumumab is that it either works or it doesn't pretty much. So we know that if you haven't had a response after a month, it's not going to work pretty much. So that's, I think, a big bonus. Velcade is, you can get in New Zealand, which is great. So I think daratumumab and AL, and I would agree with Peter. I mean, you can access diflunisal, which is basically tafamidis with side effects, and not everyone gets the side effects. So, but I think that a gene silencer, that's going to be the difference. And I think the real holy grail will be, I think that if you combine a silencer with a stabilizer, the disease would just stop. But that's so I think that diflunisal will still have a role to play for quite some time, because I don't think we'll be able to afford a silencer and tafamidis. But if you just go for tafamidis, then you've got no silencer. So I would definitely suggest going for a silencer. And I know that we've been in contact with Alnylam, and we're very keen to be involved in trials and to get compassionate access, if at all possible, in both countries. But ultimately, they're interested in getting it licensed and reimbursed by the government. And so I think that my money would be on a silencer, and I think we're probably more advanced with speaking with the Alnylam team with patisiran or vutrisiran, which is the longer acting injection in the stomach, which I think will be a lot more easy to administer.
Sorry, you go.
No, I was just going to say that daratumumab is available in New Zealand, but only privately.
Yeah, I mean, that's the same in Australia. I mean, most countries, if you want to pay for it, you can get any drug into the country. So,
Yeah.
I've
had a couple of patients who, I've said although it's very expensive, I think, because they had very, very advanced disease and it was looking very serious indeed, that, some of them had paid for a couple of infusions just to see if we could turn the tap off. So we have done that, but it's not available for everyone, unfortunately, that sort of thing.
I mean, the end game with drugs, and it's the same in New Zealand as in Australia, is get the drug available for everyone, no matter where they live, no matter whether they're rich or poor, who they are,
Yeah.
they can get the drug. And in Australia, that's to get it on what we call the PBS, which is government funded. I don't actually know what your drug list is called, but whatever's administered by Pharmac. That's the end game. And until you've got there, you can't be happy. Yeah.
Okay, so we are lobbying, we are working hard to try and get drugs, licensed and reimbursed, but it takes a frustratingly long period of time. We need pharma on board. In terms of carers and doing things, pressuring pharma to bring the drugs, but ultimately it's going to be a business decision.
Do either of your clinics have a
Complicated because we've got a cut-off depending on the age as to whether you can have AstraZeneca or not. But yes, we're telling everyone, yes, you should get vaccinated, and yes, you should get it now. Although it's not actually available for everyone. Same as New Zealand, there's a rollout sort of thing. But yes, I'm personally not optimistic that we'll be able to hold out COVID with border protection for another year. A lot of countries did very well and have an enormous outbreaks. We've had a couple in Australia that are significant. And I think the solution is that we have to get the population vaccinated. But there's a little bit of uncertainty, particularly in Australia because of these rare clots that occur with the AstraZeneca vaccine.
Peter, can I say? So if you look at the website, you can see where people are going to be able to get their vaccine. And we've already know that next month is for people with comorbid conditions, and we've arranged, for example, for all our transplant recipients to be contacted by the local regional public health. Because at this stage, with the Pfizer vaccine, you have to go to the regional hubs for the vaccination. You've probably heard recently that it may be that the Pfizer vaccine will be stable in the fridge for 21 days, which in case I think we'll start to see GPs vaccinated. But that's not happening yet.
There's a list of GPs that are doing it now, came out last week.
But it may even be more widespread. If you get your COVID vaccine in the fridge for 21 days, you can vaccinate everyone in your practice. And I think anyone with amyloidosis should be considered in that next tranche of people with comorbidity. And I think it's important that you do speak to your specialist or GP. Well, we've already got about 800 liver transplant recipients waiting to get called in next month.
I think it is important. I don't know whether there's much vaccine hesitancy in New Zealand, but there is a bit in Australia. Like Victoria's recent outbreak, vaccination rates, all of a sudden it becomes real to people again. And I just wish people in Australia would just get vaccinated. But anyway.
Yeah, the demand for vaccination in Melbourne has absolutely skyrocketed. You just need a lockdown to focus the mind. It's not pleasant, it's not fun for everyone, and I think that we had an extended period last year where we were in lockdown. We had a curfew for 6 weeks where everyone had to be inside their homes by 8 p.m. and we couldn't leave until 5 a.m. It was really, really tough going psychologically. If New Zealand gets an outbreak, that the same thing's going to happen, and you want to try and avoid that if you can. And I think that the vaccines appear to be remarkably effective and well tolerated. I think that the clotting issue with AstraZeneca is a non-starter, to be honest. It's still extremely rare. So I would definitely encourage as many people as possible to get vaccinated, and then we can hopefully get back to some sort of normality. But as I sit here in lockdown, I would encourage you all to go and get vaccinated.
Thank you, Dr. Mollee. Thank you everyone for this evening. We have an early start tomorrow at 9:30. Don't worry, you'll have lots of opportunities to continue asking questions. So for now,
Thank you to the online viewers as well for tuning in. So we'll see all of you bright and early tomorrow.